Okay, welcome everyone to this session, Social Sciences Oral Abstract session number 2. Our first presenter today is going to be India, and India is going to talk to us about the Canadian Coalition to Reform HIV Criminalization, consulting the community on criminal code reform advocacy. India, go for it.
Thank you, Isaac. I'm just going to share my screen. All right. Can everybody see my screen? So today, as Isaac talked about, I'm going to be talking to you about the Canadian Coalition to Reform HIV Criminalization's most recent community consultation on reforming the criminal code. And to introduce myself, my name is India. I'm a lawyer at the HIV Legal Network based here in Toronto on Treaty 13 territory. And I'm also a member of the Canadian Coalition, on whose behalf I'm here today. So I'd just like to acknowledge my co-authors, who are also my co-steering committee members of the coalition. The Canadian Coalition to Reform HIV Criminalization was formed in 2016 with the common objective of progressively reforming the overly broad laws that criminalize and regulate people living with HIV in Canada. We are a diverse coalition. Our membership includes people living with HIV, including people who are survivors of HIV criminalization, community organizations, lawyers, activists, researchers, academics, and more from across the country. And before I dive into the details of this latest reform advocacy, I want to provide a very brief overview of the state of the law to help contextualize the coalition's work. If you attended yesterday's session, my colleague Richard Elliott provided a more thorough overview, but I just want to highlight some key points about HIV criminalization in Canada. So first, when we're talking about HIV criminalization in Canada, we're specifically talking about the criminalization of HIV non-disclosure, meaning the criminalization of an act or omission of revealing your HIV status to a sexual partner before engaging in sex. Canada's approach to HIV criminalization is consistently criticized as being overly broad, unscientific, and extremely punitive, a position that has even been adopted by the House of Commons Justice Standing Committee, as you can see on the slide. This law is overbroad because it criminalizes people even where there is no intent to transmit, where HIV wasn't actually transmitted, and where there was little to no risk of HIV transmission. According to the Supreme Court, all that's needed to convict someone of non-disclosure is to prove that they didn't disclose their status where there was a realistic possibility of HIV transmission. This leads to the second point about this standard being an unscientific one. The realistic possibility test is not a scientific test, but a legal one, albeit one that's supposed to be based on the most up-to-date science. However, in reality, the law's definition of realistic possibility is not always aligned with the science definition. An example of this is on the point of condom use. Though we know that a condom means that there is negligible to zero risk of transmission of HIV, some courts, including the courts in Ontario, still hold that there is a realistic possibility of HIV transmission in these cases, and thus a duty to disclose. Finally, the laws are extremely punitive because the operative offense of HIV non-disclosure cases is aggravated sexual assault. This is one of the most serious offenses in the criminal code, and it can get you up to a lifetime in prison, mandatory sex offender designation, and deportation in the case of non-citizens. It's important to note that while HIV non-disclosure is usually prosecuted through aggravated sexual assault, there have been other offenses used in the criminal code, including non-sexual offenses like criminal negligence causing bodily harm and common nuisance. So amongst this harmful legal framework, the coalition formed in 2016 and in 2017 released its community consensus statement. This is a shared and unified critique of Canada's approach to criminalizing HIV and was born out of a national community consultation. To date, we've had more than 170 organizations sign on to the statement. The statement makes specific demands on federal and provincial governments to limit HIV criminalization, including through criminal code reform. Specifically, this consensus statement calls on prosecutions to be limited to cases of actual and intentional transmission of HIV. As you recall, neither of those things are required. and to remove HIV non-disclosure from the scope of sexual assault laws, while also limiting the use of other non-sexual offenses. Since the release of this statement, there have been a number of key developments from government that signal a willingness to engage on this issue, including the release of that House of Commons Standing Committee report in 2019. As it became clear that there was some political appetite for law reform, the coalition began developing concrete proposals to implement our calls to action into something that we could actually bring to Ottawa to advocate for. So in 2021, we launched our second Canada-wide community consultation. The goal of this second consultation was twofold. First, to assess whether the community still had an appetite for law reform advocacy 4 years after the release of the initial consensus statement. And two, if so, to solicit their feedback on proposed reform options in order to draft a second community consensus statement. In this most recent consultation, like the previous consultation, we consulted with people living with HIV, affected communities, HIV service providers, advocates, activists, and researchers. And due to the ongoing COVID-19 restrictions, the consultation was primarily conducted virtually through an online survey, as well as through primarily virtual workshops. Participants were consulted on 3 proposed legislative reform options, which I will outline briefly. And the survey also asked respondents whether they thought the criminal code should apply in a variety of factual circumstances, and whether the coalition should continue its advocacy efforts to reform the criminal code. We also collected voluntary demographic data to ensure representation. During the live workshops, an overview was given of the reform options, and participants were able to share their comments, questions, and concerns outside of the confines of the online survey. I'll briefly highlight the 3 options we put forward to the community in this latest consultation. The first 2 options on the screen are substantive reform options, and both would achieve the overarching goals of limiting prosecutions to actual and intentional transmission and remove these cases from the scope of sexual assault. But as you'll recall, other non-sexual offenses have been used. So the goal with these options is also to limit the use of those existing non-sexual offenses as well. In the first option, a provision would be added to the criminal code, which would shape the interpretation and application of all existing offenses in the criminal code. At the same time, this interpretive provision would explicitly prevent the use of sexual offenses. What this means is that there could be no crime under any offense in the criminal code unless the prosecution could prove intent and actual transmission. The second option is different, and it's an HIV specific offense. This offense is one that could only be used in cases of actual and intentional transmission, and at the same time would prevent the use of any other offense in the criminal code. What this means is that people living with HIV could only be convicted under this one new offense and no others, and only in the cases of actual intentional transmission. The third option, which was to accept the status quo, was included as a recognition of the risks associated with law reform advocacy. Ultimately, we can come up with our preferred reform option, but once we hand it over to government, it's out of our control, and we do not know what the final product will look like. I'll end by just sharing some preliminary results from our consultation. We received over 200 responses to the online survey, which is nearing the amount that we received from the first consultation in 2017. We had more than 100 people participate in 7 virtual meetings. And to ensure participation from key populations, we had live sessions that were organized by and for the Indigenous community, the African Caribbean and Black community, the men who have sex with men community, and a session specific to cis and trans women. And from the respondents, from the results from the actual survey itself, in the specific factual situations posed, the majority of respondents consistently felt that prosecutions were not warranted, which just confirms community consensus over these boundaries. And although we are still interpreting the results, it's clear that despite the risks of law reform, the majority of the community, 88%, support the coalition's ongoing advocacy efforts and agree that the status quo is unacceptable. So In conclusion, despite the challenges of the COVID-19 pandemic and the complexity of this subject matter, the community thoughtfully and meaningfully engaged in this consultation. This involvement has only strengthened and informed our ongoing efforts with the federal government. Meaningful involvement with people living with HIV and affected by HIV is fundamental to the reform process, and this consultation has just reinforced that. Thank you, everybody.
Thank you, India. We have time for a couple of questions. While people are thinking about questions, so have you sent the revised guidelines to government yet or not?
That's a great question. So we haven't, as a community, finalized our proposed reform option at this point, but that's something that we're hoping to do this summer, especially ahead of AIDS 2022.
Right.
But we're still in internal discussions based on the feedback received from the consultation.
Okay. But given the previous response from Parliament, are you already laying your groundwork to get some support from some groups in there?
Well, like you said, there has been some support from the government, from different subgroups of the government, including the House of Commons Justice Standing Committee. So we know that there is a political appetite for this type of reform and change. And in fact, in February, the Minister of Justice went on record saying that they're still interested in pursuing changes in this area and that they've asked us to hold them to account. Those were his words.
Okay. Are there any other questions? I don't see any question in the discussion board yet. Any questions?
And if there are no questions right now, I'd be happy to field questions over email. You can email a steering committee or get in touch with me. I'm happy to discuss offline as well.
Yeah, very good. Thank you very much.
Thank you, Isaac.
Yeah, we'll be moving to our next presenter, Waila, who is going to talk to us about HIV prevention and sexual health interventions recommended by the Middle Eastern and North African diaspora youth in Ontario, Canada, the Meena study. Waila, go for it.
Thank you, Isaac.
And I will disappear and show back in around 1 minute.
Okay, are you able to see my full screen?
Yeah.
Okay, perfect.
Can you put it in presentation mode? I see the double. It's showing the
presentation mode.
Yeah,
okay. So I'll try the other one, sorry. Okay, how about this one, Isaac?
Yeah, that's better. That's good. Okay, go for it.
Right.
Yeah.
Perfect. Thank you so much. So hello, everyone. Good afternoon. Thank you for coming out to today's presentation. I'm excited to see an interest in hearing about our study. Yesterday, I presented on some of the needs of the MSM and gay community, particularly who are from the Meena community, Middle Eastern and North African community. Today, the focus is on the interventions. So this is part 2 of the Meena study. My name is Rula Hawa. I am an assistant professor at Brescia University College at Western University in London, Ontario. I'm also the principal investigator for the Meena study. And as Isaac mentioned, we're focusing today on interventions. I would like to give credit for and acknowledge the work of my co-presenters. And these would be Vijaya Shikarmani, Fanta Ongioba, Olesia Felinchak, Basma Mu'mini, Tina Pahlavan, Lina Hamad, Rama Al-Ulabi, Anmar Al-Azzawi, Mo Al-Aqal, and Mona Lutfi. I disclose no conflict of interest. I acknowledge the support received from the Canadian Institutes of Health Research for funding the Meena study. As an immigrant and settler in Canada, I would like to acknowledge the Anishinaabe, Haudenosaunee, Lenapehoek, and Adawandran peoples, all of whom have long-standing relationship to the land of southwestern Ontario and the city of London, where I'm currently situated. This is part of our sustained practice in decolonizing our lives and work. So what does the word Yasmeena stand for? Again, Yasmeena is the youth sexual health and HIV prevention in diaspora, Middle Eastern and North African communities in Canada. It's the first study in Canada that centers Meena youth voices. Yasmeena is part of a larger research program whose aim is to promote resilience and well-being in a highly underserved youth population. The program has received additional funding from CAHR, and we're doing more work in Ontario and BC. So why the interest in HIV prevention in Meena communities in Canada? According to UNAIDS, the rise in new infections since 2001 has put the Meena region among the top regions in the world with the fastest growing rates of HIV infections globally. These global trends have implications in the Canadian landscape. According to the 2016 census, immigrants to Canada from Middle Eastern countries, particularly Arabs and West Asians, are expected to increase the most rapidly between 2006 and 2031 and more than triple in the next 25 years. Why Meena youth and HIV prevention? Youth in general, especially LGBTQ plus youth, immigrants and refugees, bear a disproportionate burden of STIs and HIV, mainly due to structural barriers resulting in social and economic marginalization. A recent scoping review that we conducted, our team conducted and published in 2022 in PLOS ONE, indicates that when we look at factors that increase risk for Meena youth, these include unprotected sex, lack of access to ART, lack of access to HIV testing, overlapping risky behaviors among youth who inject drugs, lack of harm reduction facilities, socioeconomic variables that impact key populations, and definitely number one is severe stigma around the whole area of sexual health, HIV, and STIs. And a main one for us in terms of the Canadian landscape and scene, there's a major gap in sexual health knowledge, tools, and culturally relevant resources for Meena youth. Let's look quickly at study design. So this is a community-based research study. We used a mixed methods design where data was collected using a sociodemographic survey. And we also used qualitative focus groups with 55 Meena youth ages 16 to 29 in Ontario. We used a peer leadership model where we trained 6 peer research associates who themselves facilitated 14 sequential critical dialogical focus groups with youth subgroups, including 3 focus groups involving gay and bisexual cis men, heterosexual cis men, heterosexual cis women, queer cis women, and trans women. Each group participated in 2 focus group sessions. That's the sequential dialogical approach to understand 1, youth sexual health behaviors and cultural identity, 2, gather participant recommendations for interventions. An additional focus group was done solely centered on interventions and with representation from all the subgroups for a total of 15 focus groups. Sessions were transcribed and coded using in vivo for thematic analysis, and today's focus is on the intervention that took place. What did we learn? Let's take a look very quickly at some quantitative aggregate data. And again, I've selected only very few slides just because we don't have a lot of time. So the average age was 26.9 years, and the standard deviation was 2.59. This is for the whole youth population. As we can see, 79% were born in Meena countries. And in terms of ethnicity, we noticed that the majority identified with an Arab ethnicity, 65%, 60% Middle Eastern, and 5% North African, 20% identified with a Farsi ethnicity, 15% multi-ethnic. And the majority spent less than 9 years in Canada, which is, again, an issue in terms of being newcomers to Canada. It gives them particularly very significant needs. More of the aggregate data in terms of sexual health, as we can see from the bar graph, the most commonly reported sources of information were friends, about 89%. Internet was also up there, Google searches, Reddit groups, WebMD and Mayo Clinic, 61%, followed by doctors and nurses, 50%. The least popular sources of sexual health information were mostly from mainstream health services and parents. And of course, this would be an area or both areas that we need to address in terms of intervention. What did we learn? So let's take a look at some of the intervention strategies identified by the youth themselves. So first is key behavioral interventions as identified by the participants. So in terms of behavioral interventions, the first one is informal education. And so in general, participants discussed content and education that was representative of their cultural framework, delivered in trusted community spaces or in partnership with neighborhood centers, offering workshops sensitive to sex and sexual health needs of Meena youth with language-specific workshops in Arabic or Farsi. 2, participants or youth talked about family-centered education, where resources are delivered to parents, grandparents, or youth. Overall, we noticed that youth in all the groups repeatedly talked about the significant influences that family have in the Arab and West Asian culture, and they placed value in educating family members. 3, gender-focused education. Participants specifically talked about the importance of educational content being gender inclusive and culturally relevant. For example, having trans-focused sexual health education was discussed, the need for education that addresses toxic masculinity, or having spaces for men where they can be supported to ask questions and demonstrate some of their vulnerability. What is the highest ranked behavioral recommendation based on the youth? Not surprisingly, online interactive resources. So when we look at those online resources, what would this look like? Participants described this as a tailored set of interactive resources available in multiple languages, integrated with relevant social platforms like Instagram, TikTok, and as well as in LGBTQ+ Meena influencers. Why this recommendation? Youth felt that it's more meaningful, there would be an uptake, it's discreet, accessible, it gives that anonymity in terms of seeking sexual health resources, enables young people to overcome anxiety and fear, creates also a safe space for the youth that could represent intersectionality. It's non-judgmental, and people can be empowered to seek information on their own terms. Again, looking at online interactive resources, where and with whom, this would be really pertinent to high-risk community members and particularly newcomers, and maybe perhaps those who are not very comfortable with their identities yet. Who would be delivering this? Youth mentioned religious institutions, settlement agencies, Middle Eastern restaurants, platforms where Middle Eastern shows are available, maybe where Facebook groups are. How? Or even through Meena doctors. How? In what way? You suggested live chat agent who can connect to other sources. The information has to be vetted, has to be validated and verified, and family doctors can share some of those resources with their patients. Youth also mentioned structural interventions, and these were again identified by the participants and grouped. So when we look at structural interventions, media intervention was there. It's the most frequently mentioned structural suggestion. It fell under the broad category of media intervention. It focused on increased representation of Meena identities on mainstream platforms like TV and radio. Youth in particular had mentioned subcategories like things like social media. It was a significant subsection under this broad category, cited as necessary to reach people in the community with knowledge and experiential sharing. 2, the use of apps, such as dating apps. Yesterday, we talked about particular dating apps for MSM youth. So again, these were often cited among some groups as a way to promote more one-on-one connection and support. 3, anti-stigma campaigns were discussed as opportunities for targeting education on multiple platforms, and particularly in mainstream media, to be more inclusive of Arab and Middle Eastern communities. The highest ranked recommendation for structural interventions was health navigation tools. So what would those look like? So again, The key objective for this intervention would be to create a compilation of trusted, non-judgmental healthcare services and providers, encourage queer and sex-positive spaces, train healthcare workers as required, enable community members to sift through health information online, and increase service access for those with Meena language needs. Also, youth suggested providing opportunities for decolonizing of health learning curriculum to challenge anti-Arab racism and or Islamophobia. Finally, a good starting point would be to understand the gaps within the existing training. Key biomedical interventions as identified by the participants. So no surprise, PrEP and HIV testing. The main one was really PrEP and HIV testing, mentioned by all across all groups. Normalizing testing and health-seeking behavior regarding PrEP was highlighted as a crucial sexual health strategy to counter the fear of stigma and judgment. Participants suggested youth and or newcomers can have access to kits with education information and contact links. Participants also especially agreed that PrEP should be more accessible, especially on demand, to people who may not be covered by OHIP or other insurance plans. They also said it should be cost less, maybe perhaps no money, and be as openly available quickly to order or pick up for free, just the way condoms are. So where do we go from here? In conclusion, findings from the Meena study have important implications for strengthening provision and access of care services to Meena youth in Ontario. Offering ethnoculturally relevant, non-judgmental services in community spaces is highly recommended. And finally, on a last note around funding, our work is committed to achieving a more equitable, diverse, and inclusive Canadian research, essential to creating the excellent, innovative, and impactful research necessary. And with a renewed commitment to CAHR and other funding agencies, to EDI, we're hoping that everyone would see merit in our research, and hopefully more funding will be generated for this underserved group, Meena youth. I would like to acknowledge the peer research associates for their outstanding work on the Meena study. Sincere gratitude to all the Meena youth who participated in the study. Many thanks to our community and academic partners who supported us for the past 2 years, and to the Meena youth, we're making sure your voices are heard. These are our references. And I would like to thank you for being a great audience and for your attention. Here's my email address if you're interested in reaching out maybe afterwards with any questions. I also have a Twitter handle at Rula Hawa. Meena has a Twitter account and Instagram account. We also have a website where we're housing a lot of our resources, so feel free to check that out as well. And I'm going to open it up now to Q&A.
We have time for one question. If somebody has a question. So, Roila, if there's no question, in terms of the proposed interventions, which ones will you go for first?
Sorry, in terms of proposing interventions?
There are a number of suggested interventions, right?
Yes.
My question is, which one will you prioritize first?
Okay, which one would be prioritized? I would say probably around the online resources, particularly, and peer mentorship was another one that in the interest of time, I did not include. So the role of peers in terms of particularly Meena youth is very important. So maybe perhaps offering some of the youth, maybe in particular newcomer youth, because they're more marginalized and more feel excluded and not included in a lot of services. Maybe offering some kind of mindfulness training, and then with the hope that if we do those sessions, a youth would connect with other youth and would find some networking to kind of alleviate some of the feelings of being marginalized and isolated and not integrated into the Canadian community. So this would be an option. Other options, if we are able to find a particular partner who's big on the Meena community, maybe perhaps develop some of those resources that the youth suggested and have them available perhaps on their website or through their own, if they offer workshops and groups. We're familiar with ASAP, the Alliance for South Asian AIDS Prevention. They have programming for Middle Eastern youth and Arab youth and Farsi-speaking youth. So we're hoping that that could be an avenue maybe for future funding, is to offer some of those services.
Right. Thank you very much. Great work. So we are going to move to the next presentation by Jasmine and Billy. And this one is entitled Evaluating the Impact of Undetectable U=U campaign message among people living with HIV. Insights from Ontario HIV Stigma Index. Jasmine and Billy, go for it.
Thank you, Isaac. Hi, everyone. My name is Billy Tran, and I'm a graduate student with Reach Nexus at MAP Center for Urban Health Solutions in Toronto.
Hi, everyone. I'm Jasmine Cottenham. I'm joining you from Thunder Bay, Ontario. I am a research assistant for Women's College Research Institute, as well as a community member and co-investigator on this project.
So today we will be discussing an evaluation of the impact of the undetectable equals untransmittable, or U=U, campaign message among people living with HIV. We would first like to make a land acknowledgement before we begin our presentation today. We would like to acknowledge and pay respect to the Indigenous people across the territories who are the traditional stewards of this land we are on today. We acknowledge their longstanding relationship with this territory, which remains unceded. We pay respect to all Indigenous people from all nations, including Inuit and Métis people from across Turtle Island who call Canada home. We'd also like to pay respect to the ancestors, current knowledge holders, including elders and non-human relationships that contribute to healthier environments such as animals, plants, water, and soil. By the end of 2018 and around the time of our study implementation, it was estimated that 62,000 people in Canada were living with HIV. However, it's closer to 70,000 now, with about 13% of whom were unaware of their HIV. People living with HIV are faced with significant barriers, including the lack of access to care, health issues related to HIV, and stigma and discrimination. HIV stigma and discrimination in particular have various impacts on health outcomes for people living with HIV, as it is associated with increased rates of depression and lower levels of adherence to antiretroviral therapy, or ARTs. ARTs have been used to suppress HIV viral load to an undetectable level and has been deemed a major breakthrough in HIV therapeutics in prevention of transmission of HIV. In 2016, the Prevention Access Campaign launched the U=U social marketing campaign to promote the understanding that people living with HIV with suppressed or undetectable viral load cannot sexually pass on HIV. In Canada, we have seen limited research looking at U=U among populations living with HIV. Of the 4 studies published using Canadian data, none have evaluated the campaign message among a diverse population of people living with HIV, and in particular in Ontario.
Our objective was to evaluate the awareness, understanding, and perception of the U=U campaign message amongst various key populations of people living with HIV in Ontario. Our aims were to investigate the impact of U=U on lived and living experiences, explore associations between the U=U messaging, HIV stigma, and uncover barriers to care for people living with HIV.
The Ontario implementation of the People Living with HIV Stigma Index, or the Stigma Index, is a community-led study that was designed to gather data about the nuances of HIV stigma, discrimination, and resilience factors across key populations living with HIV. It was a cross-sectional study conducted between September of 2018 and August of 2019.
Research associates, or PRAs, were employed and trained to recruit people living with HIV and administer the study through face-to-face interviews. Guided by the greater involvement of people living with HIV and the meaningful engagement of people living with HIV, or JIPA as MIPA, principles, it was important to have people living with the HIV contribute and have active participation in all aspects of the study, including implementation and dissemination.
Survey variables observed included outcome variables, various validated measures and scales, sociodemographic, mental health, and substance use factors. Outcome variables included U=U awareness, effect on personal life, perceived understanding, and U=U discussions with primary HIV healthcare providers. Validated measures included the HIV stigma scale, which encompasses internalized stigma, enacted stigma, and anticipated stigma, and protective factors including the social support scale, self-efficacy scale, and resiliency scale. We instituted the U=U questions a third of the way into the study as we believe they were extremely important at looking at HIV stigma. Participants who responded to knowledge of U=U were included in the analyses, making up a sample size of 240 participants out of the 724 we collected from. To evaluate our objectives and aims, we performed a chi-square test of independence and binary logistic regression.
The panel was made up of a majority of middle-aged adults between the ages of 35 and 54 years old. I now know that I'm middle-aged. 65% identified as male, and while an additional other category that was captured consisting of those identifying as trans or non-binary, only 10 participants responded. 55 identified as gay, bisexual, with the other category consisting of those who identified as being fluid, queer, or two-spirit. 70% completed more than a high school education, and 51% of our participants were unemployed. Our sample resided in various locations throughout Ontario and belonged to various key population groups. A majority resided in Toronto and the Greater Toronto area. Breakdown of the key populations groups varied, with 30% identifying as gay, bisexual, and other men who have sex with men, 27% as African, Black, and Caribbean, 22% as people who use substances and injection drugs, and 5% as Indigenous. We looked at how our participants thought about the U=U message. We examined the frequency of participants in agreement with the U=U outcomes and found that 96% were aware of the scientific evidence supporting U=U. 57% felt affected by U=U in a positive way, and 74% believe that the promotion of the U=U message was able to reduce HIV stigma, and 42% had their primary HIV healthcare provider discuss U=U with them.
The results of our logistic regression are presented on this slide. On the right are the variables that were included in the models, while the left side highlights our significant findings. In terms of those who feel positively affected by the U=U message, young adults, males, those identifying as straight, and those with higher self-efficacy scores were more likely to feel positively affected by the message. In terms of those who believe promotion of U=U is able to reduce HIV stigma, males, those with lower enacted HIV stigma scores, and those with higher self-efficacy scores were more likely to believe promotion of the message will be able to reduce HIV stigma. And in terms of those who had U=U discussed with them from their primary HIV healthcare provider, young adults compared to middle-aged and older adults were more likely to have their primary HIV healthcare provider discuss the U=U message with them. Our findings tell us that there's a lack of U=U dissemination from HIV healthcare providers. In order for healthcare providers to address the lack of and/or inconsistent delivery of the U=U message, targeted strategies need to be incorporated into clinical education for healthcare providers. We need to be educating our healthcare providers on U=U and providing guidance for discussions with their patients to encourage more conversations around U=U, HIV transmissibility, and promotion of health outcomes. While a majority of our sample were confident in the U=U's ability to reduce HIV stigma, more work needs to be done to improve confidence in the message among people living with HIV. Healthcare providers and educators should focus on holistic discussions about HIV transmission and the clear message that those who maintain an undetectable viral load cannot sexually pass on HIV to partners. In addition to this, promotion of the benefits of U=U on personal life and health outcomes should be discussed with patients as well.
General population should be made aware of the U=U campaign and its messaging. So these were the strategies to promote U=U. Public health messaging should include the U equals U to the general population and address stigma and discrimination against people living with HIV. Messaging should be tailored in culturally appropriate ways to reach a wider audience and a wider understanding. Other approaches for increasing communication could be the use of social media messaging or peer-delivered messaging. Those who are more self-efficacious regarding treatment and adherence to medications are more confident in the U equals U messaging. Healthcare providers need to be educating their patients about the importance of treatment adherence in order to maintain an undetectable or reach an undetectable viral load. Increased education and dissemination of the U equals U message will increase the number of people living with HIV adhering to their medications and maintaining an undetectable viral load. Expansion of supports to improve self-efficacy of treatment must also be achieved. Providing tangible supports, such as increased and easier access to treatment, is likely to increase self-efficacy and lead to positive health outcomes beyond undetectable. Thanks.
As U equals U continually gains more traction, it is important to reach populations who will benefit greatly from the promotion of the message, including people not living with HIV. We need better education and awareness around U equals U, especially in the healthcare sector. Education and resources about U equals U should be provided to healthcare providers to initiate conversations with their patients. Additionally, we need to boost awareness of U equals U and confidence in the messaging among people living with HIV and the general population. And lastly, we should be providing greater supports for people living with HIV to increase their self-efficacy. Thank you everyone for taking the time today to listen to us speak. If you'd like to reach out to us for any questions, here's some of our information, and thank you.
Thank you. And we have a question from Deborah, who says that here in Alberta, the HIV stigma index found similar findings in the lack of education being done by HIV specialists. We've done several education sessions with nurses who provide support to people living with HIV and in HIV clinics. Are you planning to do such education? How can you include HIV specialists, as we have found them a difficult group to reach?
Thank you, Deborah, for the question. I think it is important definitely to find different modes of communication and how we can promote the U equals U message. And, in the literature, we are seeing that nurses are frontline educators, and that definitely is an important avenue to reach a wider audience. And so we have been discussing ways that we can, leverage our findings and be able to do that. Nothing has been set in stone yet, but it is definitely something that should be and could be looked at as well. But yeah.
A great question, Deborah.
Thank you.
Was there another question? Deborah says thank you. So, otherwise, yeah, my comment is, it just seems to me over and over, healthcare providers are under the gun. Everywhere we turn around, it just seems to me like they are probably part of the problem. So how do we collectively get this going? Since yesterday, most of the presentations just sounds like the impediments, some of them stops right at healthcare with healthcare workers. So yeah, go ahead. I'm asking Billy and Jasmine to answer the
That's a difficult one to get healthcare providers. I mean, I think in the pandemic right now, there's a lot of priorities to get people to understand stuff. I would just possibly encourage the healthcare providers that are providing this message to their patients and the people that they serve to speak to their colleagues and let them be champions of that and talk about the benefits of and the whole health outcomes of people living with HIV by promoting U equals U.
Thanks, Isaac, for the question. I can add to that a little bit on what can be done. Australia has updated their guidance for healthcare providers as well. They've listed 5 recommendations on how their healthcare providers, should discuss U=U with their patients and promoting that as well. And while that's in the Australian context, I don't think that we're far off here in Canada, that we should be adopting some of those guidance for healthcare providers as well to, discuss that with their patients, whether it's, increasing their knowledge and understanding of what the message is saying, or how to facilitate those messages with their patients.
All right.
Thank you
very much, and very good. Great work. So we will move to our next presenter, Alan, who's going to talk to us on a topic beyond Blue Door, understanding the complex challenges of precariously insured people living with HIV accessing healthcare. Alan, go for it. I will come back up again in about a minute, but yeah, okay to go.
Thank you very much. My name is Alan Lee. I'm a primary care physician working at Richmond Park Community Health Center and also with the Committee for Accessible AIDS Treatment. So this is the partners involved in our research team, Beyond Blue Door research study. The focus of our presentation today would be to highlight part of our phase 1 findings that focus on understanding the complex challenges as well as the resiliency of precariously insured people living with HIV in terms of accessing health care. In our Land Acknowledgement, we want to join our partners to pay respect to the rights and contributions of the Indigenous people of our land. We also want to acknowledge the historic and continuous inequities faced by our Indigenous people and other racialized and marginalized communities. And we want to pledge our commitment and allyship to continue our collaborative effort in decolonializing our practices and advance social justice. We wanted to acknowledge the team that contributed to the abstract, and we have no other conflict of interest to declare. So the need for this project is really motivated by the frontline observation of increasing number of people living with HIV who face barriers in accessing care because of their precarious status or the lack of healthcare coverage. So we set up this project because we were seeing increasing number of people who have partial or no healthcare insurance coverage in Ontario. And we came together to wanted to really understand more about the disparities that led to their lack of access, but also to look at how we can evaluate an intervention that we set up in response to that, which is the Blue Door Clinic, to provide linkage to primary care and support to retention in care for these population. And we wanted to also use the research to inform policy and practice changes to hopefully build longer-term, better access system and improve quality of care. We used a mixed method design, including demographic surveys, focus group individual interviews, as well as service statistics and health outcome data from the people we serve through the Blue Door Clinic. We used a socio-ecological and population health promotion framework. And this particular presentation will focus on the findings from our phase 1 research, which includes online focus groups and individual interviews for 31 non-insured or precariously insured people living with HIV and 20 service providers from different disciplines who works with our target communities. So amongst our people living with HIV population participant sample, the criteria is anyone who have been living with HIV who has direct personal experiences within the 2 years prior to study recruitment of being in a situation with partial or no health insurance coverage, regardless of their status in Canada. In our service provider participant sample, we have a very wide variety of providers, including people from AIDS service organizations, case managers, social workers, counselors, psychotherapists, infectious disease specialists, nurse practitioners, nurses, peer navigators, pharmacists, and primary care physician. And these are just arranged in alphabetical order. So before we talk about our finding, let's just kind of give a bit more context about who are the people we're talking about. The precariously insured people living with HIV really encompasses a very wide variety of population. One way to look at that to help people understand it a little bit is we can kind of group them into three broad categories of statuses. One are people who have status but are non-insured or precariously insured. So that could be people who are actually new immigrants or new PR, permanent residents, who are in that waiting period before they are eligible for OHIP. International students and migrant workers actually have partial health coverage, but are very precarious. There's very little medication coverage, and also depending on their study permit and work permit, they can be uninsured or non-insured at any given time when their employments get terminated or when their terms of schooling finishes. There is a group of people who have pending statuses. So there are people who are applying for inland sponsorship, people who are under review or applying for humanitarian and compassionate grants for admission, and people who are waiting to start application but haven't yet made the decision or started the process of doing that. And then there's a lot of people who are kind of between statuses or without statuses, including people on foreign, on temporary workers on between contracts, students graduated, as I mentioned earlier, rejected refugee claimants that are not deported, and those who've lost sponsorship due to relationship breakdown, or those who lack ID to verify their statuses due to social situations, and people on visitor visa who actually is a status, but they might also have lapsed their visitor visas and not yet renewed. So that's a very wide range of people. We were able to invite 31 participants for this phase of our project. Over the last 2 years, we have serviced over 180 people living with HIV through the Blue Door Clinic. So these are people who are a subset of those population, but also some people who may not be clients of the Blue Door Clinic, but falls into other precariously insured categories. So as you can see, that also encompasses a variety of statuses. So there are, like, for example, returning Canadian citizens who might need to be waiting for their OHIP to be reactivated. So in terms of the gender, most of them are cisgender men, and then most of them are gay identified. A large number of our participants came from Mexico, but even within the 31 participants, we have 16 countries represented. In terms of the Blue Door Clinic, actually, we have even a larger proportion of clients who come from Latin America. So in terms of ethno-racial identity, 42% of them identify as Latin American, 6.5% West Asian, 6.5% East and Southeast Asian, and 38% Black, African, and Caribbean. So we wanted to highlight some of the challenges experienced by our participants. So we grouped them into three kind of categories. One is service user related, one is service provider related, and one is service system related. When we talk about service user related challenges, I think there is a real risk of kind of putting the blame or the responsibilities on the individual, but really it is a reflection of systemic barriers and inequities that impact on the individual level, right? So there are a lot of people with language barrier as newcomers. There's a lot of cost affordability issues in terms of how people might need to pay for medication, may need to pay for healthcare. people have experienced a lot of trauma, stigma, and discrimination, both in their home country as well as in their navigation through the systems in Canada. So that has reinforced and built a lot of distrust of healthcare system, government institutions, as well as service providers, as the previous presentation also illustrated. And then because of the social locations and the lack of access to social determinants, a lot of people have more challenges in accessing care. So for example, a lot of our service clients have very precarious employment situation with very long hours, and they may not even have enough income to pay for data plans, so they can only return, WhatsApp messages in between their shifts or during their lunch hour. And many people are also living in home situation that may not have enough privacy to be engaged in very confidential discussion all the time. So those are actual, barriers that resulted from the systemic inequities. So a lot of people also have trouble understanding how to navigate the service systems in Canada, as well as the immigration system. And people are very scared of immigration system, right? So that leads to an worsen the amount of social isolation, hesitation to access, as well as the feeling of depression and anxiety. And that is pre-COVID. So you can imagine how much worse it is after COVID. In terms of service provider related challenges, and actually a lot of them are also identified by service providers themselves. Many talked about the lack of comfort level, knowledge, and information about different statuses and the associated entitlement to services and coverage. Many are unfamiliar with precariously insured population and their needs, and express hesitancy to work with them. And many healthcare providers are reluctant to serve these populations because of the complexity in billing, the additional need for addressing language interpretation, the cost, and the lack of knowledge. And there's a huge lack of service navigation and case management support in the whole sector to support clients to access different components of care, both clinical and social, right? So lab costs, drugs for students, those are not part of the coverage. And even if people have partial health insurance, that just pay for their healthcare provider visits, but not the other associated cost. And then, of course, the other social determinants in terms of getting legal support, housing support, employment support, etc. With COVID, all of these is just gotten a lot worse, right? The services are reduced, the government processes are much slower. A lot of workplaces have to adjust their provision of services mode, and it makes everything so much harder, especially people are waiting for government processes or change in their statuses. So in terms of service system factors, there is a lot of insurance policy gaps. So students are required to buy insurance when they come to Canada, but it doesn't cover hardly any medication cost and some of the specialized labs, for example, for HIV. Migrant workers are very vulnerable to the different kind of employment situation and what the workplace is willing to support them. And then if they are between contracts, especially like for seasonal workers or farm workers, they face a lot of challenges in terms of getting continuous coverage. And we talked about earlier the delayed government processes due to COVID and the lack of dedicated funded health services to these populations, because the federal government doesn't think they are part of their jurisdiction, and the provincial government doesn't think they are part of the jurisdiction. So if people are trying to navigate between their processes or statuses, then it is really, really hard to get access. And community health centers, where I work for many, many years, are a great place to service non-insured people. But we have very limited and specific catchment and service mandate. For example, we are not allowed to service international students, and we are not allowed to serve as visitors. So we can wait till they become totally non-insured before we can service them. But while they have partial insurance and have all sorts of challenges, then we are not supposed to be helping them. So that's like a real challenge, right? And also there's a lack of clear referral pathways and information for people to really understand how to navigate different types of services. And also, as a lot of physicians talk about the difficulty of them getting paid for some of the people who actually have some insurance, but not that straightforward and not part of the OHIP system. But we've also heard a lot of resilience responses and wise practices, and people are not just like, some of the stereotype we heard for like newcomers or people without status is that, oh, they just come to Canada and expect to, get benefit from our system. Many people actually do come to escape from, more persecutory, oppressive situation, but a lot of people actually also come to contribute to our economy. As we can see from the latest stats, Canada has a really aging population and really need new immigrants and people from all over the world to support our labor force. Anyway, so some of the resilience strategies people talked about, including pre-migration planning. People actually do a lot of research online. People try to connect to community connections, and many people try to bring bridging medications with them. But a lot of times also, sometimes they get stopped at customs and people have to surrender their medication. So that was another challenge. People count on a lot of peer network for information and also for psychosocial support. And people access a lot of linguistically and culturally specific sexual health and HIV and mental health support. And many people identify community service connection as the starting point for many of their other service connection. And then having a dedicated clinic to support this population is really destigmatizing and added to the sense of safety and trust for people with very precarious statuses. And then having multidisciplinary coordinated care in one place is really important to help people address intersectional challenges, especially when people's access and availability to access service is so limited. And then ongoing provider training and mentorship is really important to increase the capacity to be able to provide services. So my last slide is about recommendations from participants. So what we've heard from our participants is that they really would welcome more resources to support some of these services that are somewhat in existence, but most of them are really precariously funded and not living up to their full potential. So service navigation support is identified as a key thing that really need to be more integrated and more structured, to help people navigate the different components of health, housing, legal, settlement needs. And linkage to continuing access to primary care is really important because a lot of times we find it really hard to refer people out from the Blue Door Clinic because there's a lack of primary care physicians and services that are willing and able to accept new clients, especially people who have partial health insurance. Mental health support is mentioned by many participants, both from the provider group and the people with HIV groups, especially in terms of addressing depression, addiction, and substance use issues. And then core funding and ongoing care provision through non-insured HIV clinic is really important because that doesn't really exist for the Blue Door Clinic. It's a pilot project that is counting on the goodwill and pro bono donation of staff services from many of our partner organizations. People also talk about having a centralized mechanism to help coordinate treatment access and service referral would be really helpful because as great as we have in Ontario and in the GTA area with many service partners, which is really helpful, it's also really hard for people to navigate and be knowledgeable about all of the different things, right? So having a more coordinated, centralized approach and mechanism so that people can access those information much more easily would be really helpful. And to reduce the siloing of services more, having more collaborative planning is really important, and increasing training for providers, especially to provide like a stigma-free, trauma-informed, and culturally safe and responsive care to these diverse population group is really important. And then, of course, having universal access to treatment and healthcare is really important. So one thing to really note is that during the pandemic, the Ontario government actually have a bulletin that would allow for universal access, so to speak, regardless of health insurance. But in practice, we still see that a lot of our population is really scared to access those services because it will involve disclosure of their lack of statuses, and also it, hospital is not the safest place for people to access during the pandemic, or so they were perceived, right? So we didn't really see that a lot of our care were able to be transferred to other institutions during the pandemic, even with that provision. So I think having a more community-based, and also we also still get referral from hospitals who refuse to care for clients without status, even with this government policy. So we can imagine when this is lifted, or when this is no longer practiced after the pandemic, this will make things even a lot worse. So I think that's basically what we wanted to share with this particular presentation. We hope that it will provide some useful information for you and motivate you to get more involved in serving this population. If you want more information, you can access, you can email me, and you can also access the website of the Committee for Accessible AIDS Treatment, which is the CAT link one, and also the Blue Door Clinic webpage for more information about actual service. Thank you very much.
Yeah, thank you. We have to move on now. For those who are here to listen to Colin, can you take it from here? Colin, are you there? I don't think we can hear you.
Oh, sorry. Thank you, Isaac. I was just saying thank you actually to you for your moderation, which I especially appreciate after that start. And thank you so much to all the panelists as well for your contributions to our discussion. Okay, I think we're good now. I also want to begin by acknowledging that the territories where I live and work in Concordia University, where I'm based out of, are located on unceded Indigenous lands of the Ganahanaga Nation. So as I said, I'm a postdoctoral research fellow at Concordia University, and I'm also a member of the Canadian Coalition to Reform HIV Criminalization, whose work India spoke about at the start of our panel. And today I'm going to share updated data on the key trends and patterns of HIV criminalization in Canada. The full report that was authored and published by the Legal Network, co-authored by myself, Natisha Massakoy, Richard Elliott, and Eric Michalowski, can be found online on the HIV Legal Network website. And I can post a link to that into the discussion board following this presentation as well. As my colleague India described earlier, there are widespread efforts underway to limit the criminalization of HIV in Canada. And our hope is that this report provides data to support this ongoing advocacy work and to end the harms of HIV criminalization. This analysis that we've conducted updates earlier reports that were published in 2012 and in 2017. So one of the challenges of studying the trends and patterns in HIV criminalization is that there's actually no official tracking of HIV non-disclosure cases in Canada. So in the absence of a more stable central database, we've drawn on various methods to produce this report. This involved reviewing information on criminal trials that were compiled by the HIV Legal Network. We also reviewed media reports and legal documents that were identified through various databases. We also consulted with other colleagues across the country who are conducting critical studies of HIV criminalization. Our report only examines cases of criminal prosecutions for alleged HIV non-disclosure in the context of otherwise consensual sex. So this tally of cases does not include cases of forced or coerced sex where HIV might be an aggravating factor, nor does it involve cases of assault that involve someone living with HIV where they're accused of spitting or biting someone. So this table here provides an overview of cases since 1989, and we can see that there have been at least 206 people prosecuted in 224 different criminal cases in Canada between 1989 and 2020. As you can see in this table, HIV criminalization cases have actually declined in recent years. And this drop likely has to do with the solid and sustained advocacy efforts that have been going on across Canada. You'll see in the report that we trace some of the major milestones in advocacy to challenge how the criminal law is applied in instances of alleged HIV non-disclosure. The vast majority of cases since 1989 have been in 3 provinces, Ontario, Quebec, and British Columbia. Ontario accounts for just over half of all cases, more than 3 times the number of cases than any other province. The large number of cases in Ontario reflects 2 things. First, the fact that the province accounts for the highest number and proportion of HIV diagnoses in Canada, and also has to do with the prosecutorial approach in the province towards instances of alleged HIV non-disclosure. While we don't have time to sort of detail the entire report today, I'd like to highlight 3 main areas of concern that emerge from our study of the trends and patterns in HIV criminalization. These concerns all underline the urgent need for the criminal legal system to be better guided by science and human rights principles in responding to HIV, and for government action to end the harms of HIV criminalization. So first, when we look at the data, we can see that the criminal law continues to be used disproportionately against people living with HIV from some racialized populations. So here we can see the proportional distribution of people living with HIV who have been charged for HIV non-disclosure between 1989 and 2020. In previous reports that we've conducted on the demographic patterns of HIV criminalization in Canada, we've underlined that Indigenous women are disproportionately represented in HIV criminalization prosecutions. And this trend remains stable as we write in 2020. Given the disproportionate representation among people living with HIV in Canada, Indigenous women are heavily affected by the threat of potential prosecution. In Canada, qualitative studies show that Indigenous women living with HIV experience over surveillance by health officials, police, and the law as a form of colonial surveillance and racism. In the report, we also outline a number of different ways to assess the disproportionate representation of African, Caribbean, and Black people among those charged, and show that there is cause for serious concern regarding the high proportion of prosecutions against African, Caribbean, and Black people, particularly men, compared to their representation in the best available national data regarding the racial demographics of the HIV epidemic in Canada. Now, looking at the proportion of criminal prosecution really only tells us part of the story about how race and racism shapes HIV criminalization in Canada. Another way to look at how the criminal law is applied is to examine the outcomes of criminal cases. So what you have here is a chart that starts with an acquittal rate, and then we have cases in which a person's charges were dismissed, stayed, or withdrawn. This basically means that the court has decided after looking at a case that a person is no longer charged with a criminal offense. And then we have a conviction rate, so all the cases in which a person is found guilty. When we look at the breakdown of legal decisions by race, we can see that there are notable differences in the outcomes of HIV criminalization cases by race that raise major concerns about how systemic racism affects the outcome of cases. We can see here that Black and Indigenous populations have lower rates of acquittal and of having charges dismissed, stayed, or withdrawn, and have a higher conviction rate. Meanwhile, white people have the highest rates of acquittal and charges dismissed, stayed, or withdrawn, and the lowest rates of conviction. We also want to look at what happens after the legal decision when a person is sentenced. We know that overall, a large proportion of HIV criminal non-disclosure cases result in prison sentences. And on this chart, you can see that the y-axis shows the number of people and the x-axis shows the race of people who face charges. And we can see here that African, Caribbean, and Black people and Indigenous people are more likely to face prison sentences than white people in HIV criminalization cases. Of the 51 cases resulting in a conviction that involved a defendant who is African, Caribbean, or Black, 37 out of 51, or 73%, resulted in prison sentences. Of the 16 cases resulting in a conviction that involved a defendant who is Indigenous, 12 out of 16, or 75%, resulted in a prison sentence. And in contrast, of the 80 cases that involved a white defendant, 45 out of 80, or 57% of cases, resulted in prison sentences. So overall, this updated analysis of the demographic patterns in HIV criminalization complements other work that has analyzed racism manifesting in the phenomenon of HIV criminalization, including in media coverage of prosecutions. A second area of concern is that people living with HIV continue to face very serious criminal charges in cases in which their sexual activities pose a negligible risk of HIV transmission or no risk of HIV transmission at all. So of the 224 cases between 1989 and 2020, there have been these 163 cases in Canada in which the HIV status of the complainant is known. And we can see here that there was no HIV transmission in 64% of these cases. And this trend actually seems to be intensifying. Since 2017, there have been 16 cases in which the HIV status of the complainant is known. And in 75% of those cases, there was no transmission. So this is demonstrating that most HIV non-disclosure cases are about an alleged or real exposure to the virus rather than actual transmission. Looking more specifically at the cases that are resulting in convictions reveals that most people convicted for HIV non-disclosure did not transmit HIV to their sexual partners. Of the 130 cases that ended in conviction since 1989, there are 114 cases in which we know the status of the complainant. And this shows that of those 114 cases, there was no HIV transmission in 56% of cases. So this suggests that there is need for continued advocacy to ensure that criminal legal decisions are informed by the most recent scientific data on HIV transmission. The final concern that we want to highlight today is that the Canadian criminal legal system's approach to HIV non-disclosure remains exceptionally punitive. There are stable trends that suggest that HIV non-disclosure cases have very high rates of conviction and that a large proportion of cases result in prison sentences. A significant majority of cases have ended in conviction. 70% of all cases since 1989 ended in conviction on at least one charge. And it's also worth noting that since 1989, 64% of convictions have been the result of a guilty plea rather than a guilty verdict following a trial. The sentence is known for 124 of the 130 cases since 1989 that ended in a conviction. And we can see here that only 6% of cases involved the defendant given a conditional or suspended sentence where they didn't face prison time. An overwhelming majority of the cases, 94% of people convicted in HIV non-disclosure cases receive prison sentences. And as we've noted, when we disaggregate that 94% by race, it shows that African, Caribbean, and Black and Indigenous people are more likely to face prison sentences than white people. So again, we would invite you to review the full report on the Legal Network website, but overall, the report provides evidence that substantiates ongoing concerns about HIV criminalization in Canada and highlights the urgent need for the criminal legal system to be better guided by science and human rights principles and for government action to end the harms of HIV criminalization.
Oh, very good. We have time for a couple of questions. So Collins, the same type of question I asked your colleague. how are you going to get this out there to the, to the lay person? In other words, knowledge translation. If you put this in reports and it ends up with the politicians and the court system, nobody will know. We just sit on it, right? So how do we get to know, what are you going to do so that a lot more people will be like, whoa, what's going on?
Yeah, thank you so much, Isaac. That's such a good question.
Yeah.
I think we have in the coalition, we do have a media working group that is working. We have a big advocacy push coming in line with the World AIDS Conference coming to Montreal in a few months. That represents a really important opportunity for us to distribute these findings.
Mm-hmm.
One of the main concerns about how HIV criminalization cases are covered is that reporters will often just take content directly from police press releases about these cases, which means that ostensibly we have the police who are writing stories about HIV criminalization cases. So one of the most important aspects of producing reports like these is that it provides a text that can actually compete with police documents and provides a different source that reporters can draw on when they're covering these issues. India, who presented earlier, has worked tirelessly over the last few months and has been involved in a number of media campaigns and doing really fantastic interviews to distribute this sort of information. So it's part of a broader strategy that we're doing to try to change the criminal code over this next push.
Yeah, there's a question from Deborah. How can we get involved in changing these laws and the way people live with HIV, especially those from racialized populations, have been treated by the legal system? So in other words, almost similar to what we're saying, how can people like us, how can we get involved?
Thank you so much, Deborah. That's a great question, and really pleased to hear that people are interested in being involved. You can check out the Canadian Coalition's website and social media presence. I can add some more links to the discussion board as well. It'd be great to have people involved in any of those ways, and to distribute reports like this on social media or whatever platforms you're sharing information on would be greatly appreciated. And I'm happy to chat further with Deborah and other folks as well about more specific ways that people can be involved.
All right. Great job. Thank you very much.
Thanks so much.
We'll move to our next presenter, Rusty. Is that right? Yeah, I think, yep. And Rusty is going to talk to us about migration and health, a migration and health study, findings from an exploratory qualitative study of sexual health among racialized migrants in Manitoba, Canada. Go for it.
Thank you. Thank you so much, Isaac, for your facilitation today. And thank you to all the great work and great presentations today. So hello, everybody. I will be presenting work from our recent study here in Manitoba on sexual health among racialized migrants called the Migration and Health Study. I am presenting this work on behalf of our team, myself, and also our colleagues, Chinyere Njeze, Bolaja Kinile-Kambe, Patricia Yukoli, Mike Payne, Laura Ringert, Gail Restal, and Linda Larcombe. So my name is Rusty Suleymanov. I am an assistant professor in the Faculty of Social Work at the University of Manitoba. And I'm also the director of the Village Lab, which is our community-based health research lab focusing on key and priority populations in HIV research. So I would like to start first with the land acknowledgement. I live and I work on the lands that belong to Anishinaabe, Cree, Ojibwe, Dakota, and Dene people, and the homeland of the Métis Nation, or what majority know as Winnipeg. We respect the treaties that were made on these territories. We acknowledge the harms and mistakes of the past, and we dedicate ourselves to move forward in partnerships with Indigenous communities in a spirit of reconciliation and collaboration. In the current times of pandemics and global wars and this conference taking place remotely, it's just really important to be grounded on the lands where we are. And I also like to acknowledge that the water that we drink here in Winnipeg is sourced from the Shoal Lake 41st Nation. So in terms of the work that we do here, the Migration and Health Study that project really aimed to understand the health and well-being of racialized migrants in Manitoba, immigrants and refugees, with a particular focus on HIV and sexually transmitted and bloodborne infections. To our knowledge, this was the first study of this kind in Manitoba, and as you could see, was supported by a variety of agencies, community-based agencies, regional health authorities, academic partners, and the federal government. We were able to recruit 34 individuals for this qualitative project from African, Caribbean, Black communities, Latin American communities, Middle Eastern, and East and Southeast Asian migrant communities across Manitoba, including Winnipeg, Brandon, Steinbach, and Thompson. And what you see on your right is just a little bit about inclusion and exclusion criteria. This was our recruitment poster. So we conducted semi-structured interviews with participants, asking them questions on their healthcare access, knowledge of HIV, STDs, and sexual health in general, and their experiences with healthcare providers. We conducted interviews in 8 different languages for individuals who didn't speak English, including, so besides English and French, we did it in Tigrinya, Swahili, Arabic, Spanish, Tagalog, Mandarin, and Cantonese. Interviews lasted approximately 1 hour in duration, and we paid $75 for this 1 hour interviews. So the data were subjected to thematic analysis. After we analyzed our data, we brought this back to study participants to member check their stories with them. And we also had a community guiding circle consisting of 10 individuals from different migrant communities who also provided some validity and discussion on this data. So a total of 34 individuals from different communities. You see a small number of demographics presented on your screens. Some other information I'd like to share with you is the age range of participants was between 22 to 54. The average age was 35 years old. Approximately 18 individuals had children. The number of years participants lived in Canada ranged between 1 to 26 years, but the median age was 4. So on average, people live here for about 4 years. The key themes I'm presenting on today are categorized in 4 areas: HIV, STD awareness, testing, and sexual practices, sexual health information needs, impacts of gender, culture, and religion on sexual health, and some stuff on stigma, social exclusion, and experiences of racism. So in terms of the first major finding that we found is there were very different levels of knowledge and experience with HIV and sexually transmitted and bloodborne infections. And this knowledge really appeared to be mediated by numerous factors. Country of origin, like if somebody comes from a country where HIV is endemic, length of living in Canada, education, how involved they are in a variety of services already in Manitoba. So really got a lot of different narratives, which kind of, it was almost like a continuum from participants, for example, who had very little knowledge about HIV, very little knowledge about where to get tested, as you can see on your screens, to individuals who had a lot of knowledge about HIV, biomedical HIV prevention, things like PrEP and TASP. For example, the quote that you see in front of you from this particular participant speaks about how PrEP was a big deal for them. Other individuals spoke about, showed a lot of kind of awareness about HIV. And for example, this particular quote, "My partner, he's HIV positive, he's on meds. I would rather sleep and have unprotected sex with a man who will tell me that they're positive, but undetectable, instead of going to sleep with somebody who tells me that they're clean," and stuff like that. So what you could see is really biomedical HIV prevention discourse was such a salient discourse, and really people even relied on their knowledge coming from biomedical prevention to engage in sexual practices. Our findings also highlighted the issue of access to sexual health information, particularly in languages spoken by migrant communities, and as well as the need to access this information at community-based agencies, not just at healthcare centers, not just at doctors' offices, but really at organizations, social service organizations, in the immigrant and refugee social service sector. So they wanted more campaigns, they wanted more information. And so this finding is really important because it speaks with regards to how I think sexual health discourse circulates within immigrant and refugee social service sector here in our province. Other findings, other very salient findings also emerged with regards to the impact of culture, religion, and gender norms on sexual health and sexual practices. So, for example, the following quote here in front of you exemplifies some of the responses where participants evoked gender norms and roles when speaking about condoms, whose responsibility it was to have condoms during sexual intercourse. But other participants also commented, as you can see from the second quote, on how cultural and religious attitudes discourage communication about sex, communication about safer sex practices, and sometimes communication about birth control. Finally, and probably not surprisingly at all, the study revealed the impacts of HIV stigma and racial discrimination, racism in healthcare contexts, which negatively affected participants. So this quote speaks about this experience of racial discrimination in healthcare. I had to get a test, a yearly checkup, and the woman asked me where I was from. Because of my accent, she assumed maybe I just arrived. Because I'm from Kenya, she assumed that I have to get an HIV test. I was like, I've lived here for a long time and I'm very safe. Right away, she was like, well, we have to give you an HIV test. I'm not against testing and all that stuff. It's just the way it happened. It turned me off. It hurt my trust. So you can see how this really affects engagement in healthcare, how it affects the rapport and trust in healthcare providers. There was so much stuff on anti-Black racism and anti-Asian racism that emerged from this study and how it really affected these communities. So take-home messages. Well, overall, our work really complemented work done in other provinces, and we know this. That some of the findings were similar to work done in other jurisdictions, but with regards to different barriers, with regards to different challenges that affected the sexual health of racialized migrants in Manitoba, our study really illustrated the silos, the gaps between our sexual health and immigrant and refugee sector. And the role, for example, that stigma, racial discrimination, gender and cultural norms all played in the development of potential negative health outcomes is really of importance here as well, because service providers, researchers, policymakers, funders, they should all consider the impacts of those socio-ecological factors on the development of healthcare barriers, negative health outcomes. Racialized migrant communities really deserve and need access to safe, non-judgmental, culturally responsive, trauma-informed healthcare, and from providers who really understand their needs. So the big question that is on our minds in Manitoba now, having those findings in our hands now, is how can we move forward? How can we ensure that we can create anti-racist spaces in primary healthcare in Manitoba? So this study also, just want to acknowledge that a lot of diversity has really emerged depending on which countries participants were from. So it's hard to make kind of big generalizations or comparisons, but some of the findings with regards to racism and just negative experiences that participants had in healthcare in Manitoba really show you the picture that we find ourselves in. Where we are right now in terms of actually moving this work to the action stage. We're holding meetings, discussion tables, circles to bring together community-based organization, sexual health and immigrant and refugee sector agencies, regional health authorities, policymakers, health strategists to design campaigns, to design workshops for communities. With regards, for example, to sexual health information needs, there appears to be some communities who maybe still have this need for linguistically congruent sexual health information. For migrants at health agencies, doctors' offices, but also community-based social service agencies in the immigrant and refugee sector. To deal with stigma, we really need community-based initiatives, campaigns, public awareness campaigns, really aimed at destigmatization, really aimed at transforming maybe the inequitable gender norms to improve uptake of sexual health related prevention. And our findings really highlight the need to build partnerships, really to build those alliances between immigrant and refugee sector and the health and maybe HIV sectors provincially. The two sectors in Manitoba currently work in silos, and there's an obvious need to create a platform for this kind of intersectoral, interprofessional collaboration. So this is kind of coming to an end for my presentation. It really took a village to do this kind of work. So I want to thank all the communities, community guiding circle for this project, service providers of community-based organizations, our interpreters, and the research team, and of course our funder for allowing us to do this work. This study also led to the development of new research projects in Manitoba, and for which we're very thankful. And if you want more information, you can contact me, and feel free to follow our work on social media. Thank you so much.
All right, thank you. We could take one burning question, if there's one. There's a question from Josephine. It's great to learn about the sexual study with immigrants in Manitoba. Have you thought about connecting with researchers in other provinces?
Yes, absolutely. We are connected with researchers in Ontario. We are connected with researchers in British Columbia to better understand how they've done similar work, some of the kind of their challenges in doing this work, but also their success stories, their best practices. Like I said, the study also led to the development of new research projects, actually specifically focusing on Black, African, and Caribbean communities here in Manitoba. One of our partners is actually here in the room here today, Wangari Tharau. So yes, we are doing a lot of work interprovincially as well.
All right, thank you, Rusty. We are going to move to our last presentation. And this will be by Aaron. And the title is Meaningful Research Methods in Indigenous STBBI Research. Aaron, take it from here.
Okay. Is sharing the presentation, yes? Yes, okay. Okay, so hi everyone, my name is Aaron Lee. I am a social work PhD student from McMaster University, and I'm just here to speak on a research project that I'm doing on behalf, we're doing on behalf of the Fee Center for Indigenous STBBI research on meaningful research methods in Indigenous STBBI research. And so I'm speaking, just going to start off with a quick land acknowledgement. I'm speaking from Toronto, which recognizes the traditional territories of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, which is now home to many diverse First Nations, Inuit, and Métis people. So as a quick background about the FEAST Center. So the mission of the FEAST Center for Indigenous STBBI research is to establish, implement, and sustain strategic research programs and initiatives through a national network with strong academic community and intersectoral partnerships. The FEAST Center is guided by three methodologies, including Indigenous knowledges, decolonizing methodologies, and community-based research. Now, speaking on the project that I'm going to be talking about today, the goal is to examine how Indigenous knowledges have shaped and created research methods. We want to take a look at how research has been decolonized through the use of Indigenous knowledges. And we want to see how Indigenous knowledges have created and developed new research paradigms. So I'm going to pull out and highlight some of the key findings and themes that we have from this literature review. And just try to draw a kind of a continuum of some certain themes that we're talking about. And so the objective is to conduct a rapid review of the literature to identify these common themes and hopefully to ground future FEAST-centered research programs, including workshops, modules, et cetera, and stuff like that. So in order to gather the relevant literature, we used a rapid review protocol, which is very similar to a scoping review protocol. And it began by creating a list of search terms that would be relevant to our study. And this was collaboratively developed with the FEAST team with help from an external librarian. The databases we used include PubMed, NBase, ProQuest, EBSCO, and Web of Science. That way we cast the net fairly wide in order to pull out literature across the 4 pillars of health. And since it was a rapid review, and since we didn't have the resources to fully extract like all as much gray literature for this study, and so we made it so that only peer-reviewed articles were included in this project, published within the last 5 years and written in English. And so from those 4 primary databases, we ended up pulling out 1,300 articles or 1,299 articles. And from there, it went through a screening process where the article would only be included if it had an exclusive focus on Indigenous peoples, an exclusive focus on STBBIs, and whether or not the article contained a commentary or a theoretical description of how Indigenous knowledge have informed the data collection method. Once we scanned all those articles through the abstract and then through the full article, we were left with 142 articles. From there, we took those articles and we uploaded into Google Sheets at the time for collaborative coding. And then they were organized based on the CASP headings, which included methodology, methods, data analysis plan, plans for knowledge translation and stuff. Other categories like that. And then we later circulated summary documents to just have a discussion about what type of themes emerged from there. And so I'm going to be talking about 3 main findings from this literature review. And the first one I'm going to talk about is the building of cultural safety and cultural context. So working towards establishing cultural safeties, a lot of the researchers drew on the knowledges and expertise of local community members to help guide the research process. And this included discussions about the research design, the data collection process, the analysis, knowledge translation. But it all centered around ensuring that the project was focused on producing an outcome that's culturally relevant and applicable to the research community. And therefore, in order to do so, the establishment of a culturally safe paradigm was fundamental to making sure that the data collection tools would achieve the necessary findings to produce a community-driven outcome. But in order to do so as well, they involved the community members by providing roles and responsibilities. But underlying these roles is the expectation that the research would be conducted and performed in a culturally safe way and a meaningful way that aligns with Indigenous ways of knowing and doing. And to do so, the community members were often brought in to help design these culturally safe spaces. And these included the community members included peoples like elders, leaders, traditional authorities, cultural mentors, knowledge keepers. But it is a partnership after all. And usually within these research projects, there are members that are considered outside from the Indigenous communities. And so for the outsiders, they do hold a responsibility as well in understanding how their positionality positionality could jeopardize or impact the creation of such spaces and how they should approach these circumstances. And these often came in the form of cultural awareness and cultural training for those who are new to the world, or even as a refresher for those who are new to Indigenous methodologies. So what are some of the outcomes of doing so? So Indigenous peoples are given a space where their voices, identities, and stories can be heard and respected. And especially in a field where drug use and STBBIs are highly stigmatized, the establishment of a welcoming setting that's judgment-free not only allows these participants to express their various identities, but also provides a safe space to practice cultural identity. It extends beyond recognizing the potential harms of discrete triggers, but represents an opportunity to dive deeper to involve community members in dictating these research processes. Next, we look deeper into how Indigenous methods involve community. Now, I touched upon that a little bit before, but many articles in this literature review employed members of the community to help through data collection. So those who chose to employ a mostly Indigenous research team, they would involve members of the community with extensive knowledge at the local level or hire a group of Indigenous peoples with the intention to build research capacity. And so this allows the community to take ownership of the research project and implement knowledge translations activities in their own community context. It's almost as if the methods were a pilot project that would also be used within their own communities and brought the knowledge back there. So given the stigma, the highly stigmatized nature of STBBI topics, a number of these research projects were used to build these educational materials, and it drew on the expertise of the community to spearhead these movements. And to provide an example of one of these is a number of studies involved in this project brought in youth. So as an example of how the youth were engaged, youth research coordinators were hired to organize and develop their workshops and responses to local community needs. They're responsible for liaising and working with other Indigenous youth to facilitate these workshops, and then to conduct these research activities within their own local network. And so there were also they also helped with the review of the final interpretation of data, and making sure that everything is culturally relevant to their own communities. Next, we took a look at the language considerations, and here we start to move towards where Indigenous knowledges are starting to embed themselves within the research data. So the previous two talked a little bit more about how Indigenous knowledges and some of the research methods work alongside each other. Now we're dipping towards the other side of the continuum, where Indigenous methods really drive the direction of the data collection process. So knowledge keepers and community members would help in describing the purpose, the design of the research questions and shaping the research process. And this determined how the research was collected and implemented. And so it was beyond simply using terms that were culturally sensitive or building a culturally sensitive space, but drawing directly on Indigenous languages and concepts so that the research participants can share their experiences, ideally without the influence of Western colonial thought. Although that would be the goal of doing so. And so the use of Indigenous language within research methods represents an instance of opportunity and resistance for Indigenous communities to take ownership of these research process and push back against colonial thoughts. In doing so, it directly shapes discussion and sharing by taking the extra step to reconceptualize English terms in accordance with Indigenous epistemologies. So more importantly is that research participation is now carried out according to the values that are in alignment with Indigenous life, Indigenous ways of knowing. It helped reinforce the values that were taught by elders, and it helps embody community concepts, making things more tangible and relatable to the community. And so with the use of indigenous knowledge, it creates the option to create these things, to discuss the topic of STBBIs in their native language, and opens possibilities for the reinterpretation of ideas that would not have been previously adequately expressed in English. And so for the last thematic finding, it's currently labeled as contextual consideration, but it's more so of a immersion of indigenous methods within indigenous worldviews. It falls more similar to the context shaping research. So it's not simply about building cultural safety anymore, but bringing in traditional practice into these spaces and allowing things like traditional foods, traditional ceremonies, and incorporating local celebrations to shape the way data is collected. And in the context of STBBI, it provides an added bonus of enhancing comfort and mutually supporting each other on a sensitive topic and related issues within a space that's less about research, but more in alignment with indigenous ways of knowing and being and relating with one another. And so some examples of doing this is using workshops to gather data while simultaneously designing things for future workshops in knowledge translation. Some examples include group storytelling, sharing circles, photography, recording sessions, cultural ceremonies, excursions, and the last one was dinner table methodology. Forgot the exact wording. It's when you share food and while doing research. And so these are grounded in indigenous ways of knowing, and whether through stories, personal insights, role play, and symbols, these facilitated workshops provide a way to link directly indigenous knowledges with community building and knowledge translation. Right, so taking some of these findings that we had, what did we learn? Is that, these are three of the ways in which indigenous knowledges are integrated within research methods. We do need to continue to develop a better understanding of how indigenous knowledges reshape research methods within the context of STBBIs. And so we hope to have further discussions about how indigenous knowledge continues to challenge, shift, and change our understanding of STBBI research. And beyond looking simply at indigenous culture, increased reporting of how culture is integrated in research. And by saying that, what I mean is broad blanket statements of integrating traditions and ceremonies, but how exactly do these things change how data is collected? And I want to thank everyone for attending and listening to my presentation. And yeah, that's it for me.
Thanks, Aaron. We have time for a couple of questions. So while we are waiting, so Aaron, you mentioned under the community involvement that the potential of training new rules geared towards knowledge translation. What exactly do you mean?
I didn't understand.
You talk about creating new rules, right? In the community for knowledge mobilization and translation or something like that.
Creating new what?
New rules, like new,
okay.
Yeah. You said to create new rules geared towards knowledge mobilization in one of your slides. No, you don't remember? New rules.
No, I'm trying.
Were you going into a community to select specific people and train them to be for a particular role? Is that what you are talking about?
Oh, roles, not rules. Okay, roles. Okay, yes. And so what's the question?
So what were you thinking? What exactly are you suggesting?
Oh, okay. So different roles that you can take on as part of these different type of methods. Again, this is a literature review, so I'm pulling out different examples, right? So different studies have hired research people from the community to be research coordinators, right? And they would help with reaching out to the community, establishing community connections since they are directly from the community. Other studies have hired younger students like high schoolers or undergrad students to help deliver these carry out these research methods, right? And it's a good way for them to become immersed within the world of research and seeing how community initiatives emerge from research and connecting academia with community. And other roles that are less formalized and less rigid, right? There are roles such as advisory councils for elders and those knowledge keepers to just come in and provide guidance, roles for elders, roles for those to just provide support in any way. Many different ways, but just a very common theme that emerged from these different types of Indigenous SDBBI research projects is that there was always some form of direct involvement from the community or partnering with community organizations, so that there is a direct role that is outlined of how the community is not only involved, but what is expected of one another, and how it is a mutual partnership more than anything else.
Okay, good. I don't see any other question. Is there any question? If there's no other question, yeah, we had one presenter, one less, and we are right on time, actually. Only 6 minutes late. So thank you all for coming. Great session, and that was really good. If there's no other question, I will declare that we close the session. Bye.